right, so welcome to another edition of the Deals for Dentists podcast. And today we are joined by Dr. Joseph Krainin. He is the president and founder of Singular Sleep, and he is zooming in from Jacksonville, Florida. Their home sleep apnea test program helps dentists conveniently test patients for sleep apnea, and their online sleep doctor can collaborate with you in the management of complex cases. Go to Deals for Dentists and find Singular Sleep's offer. And they offer a lot of packages actually. So they are offering a home sleep apnea test, $250, which is normally $295 when patient orders directly. They're also offering 2 home sleep apnea tests, diagnostic and follow-up with oral appliance for $450, a home sleep apnea test with online sleep doctor consultation to provide a prescription for an oral appliance and medical codes. That's $375, which was normally $490 when the patient orders directly, or 2 home sleep apnea tests and an online sleep doctor consultation for $550. You can include the cost of the above services and what you charge your patients or bill insurance. Well, thank you so much for joining us, Dr. Krainin. I look forward to this interview.
My pleasure, and likewise.
So we have 2 Josephs in the room, but my podcast guy here is Jofus. That's what my 5-year-old, how he pronounces his name. He keeps, so he's officially become Jofus. So you are a board certified neurologist and board certified sleep apnea specialist. Is that right?
Correct. Yes.
Okay, and you did your fellowship at the University of Michigan.
Right.
You're originally from Norwell, Mass. Go Blue. You're originally from Norwell, Mass, and you were elected to the Norwell Athletic Hall of Fame for football. So you must have a Tom Brady Michigan jersey framed in your bathroom like my friend Rodney, right?
I wish. That would probably be worth a lot, especially if you could have gotten him at when he was at Michigan. But unfortunately, I don't think anyone saw. He was there before I was there. I did my fellowship 2008 to 2009, but I don't think anyone saw his talent. Bill Belichick did, obviously, but he's one of my idols, especially as I'm slipping into middle age here. Just turned 45, and he gives me hope that. We can age gracefully as men and still be useful on some level.
Now you went skydiving on one of your birthdays?
I did, yes. I the 3 things I was most afraid of in life, I knocked them out in short order. So one was getting married, another was having a child, and the third was jumping out of a plane. And in a couple year block, I did all those 3 things. And the skydiving was, not gonna lie, it was really, really scary. The hard part was getting your body to the edge of the plane, willing yourself to do that. And then at that point, you're tethered to the instructor. They push you out, so you have no control over that. But after that, it was actually not that bad. It was really, I was able to be in the moment for the free fall and the experience and really enjoy it. It was actually probably a little bit less scary than hang gliding, which I'd done in Brazil maybe about 15 years ago. There you have to will yourself to run off of a cliff. That's really, really hard to do. And there's a free fall, you get a free fall with the skydiving, but you hit terminal velocity very quickly where you don't have that sinking feeling in your stomach. Mm-hmm. You get that with the hang gliding a little bit too, but that's kind of scarier because it looks like you're going to just fall down and hit some trees, but then you catch the wind and then the pilot kind of gets you going in an updraft. So it was a great experience. I think maybe when I'm 50, I'll do it again. But something you don't want to do too much. I've read, and people I know in insurance say, like, it's, if you keep doing it, your time is going to run out if you do enough jumps. It kind of, the odds are against you. But I would recommend everyone try it once.
And you've surfed all over the world as well?
Yes, yeah. Surfed mediocrely all over the world. Grew up in the South Shore of Boston, and the waves, unfortunately, typically are best in winter. So we would go to Scituate and Hull. I can't believe I did this looking back, but it would be like December. The water would be in the upper 30s. I'd have a 5 millimeter wetsuit on with hood and lobster claw gloves and boots, and go trudging through snow. Then I did my residency in California in neurology. Part of the reason I wanted to go out there was I'd fallen so in love with surfing. But after that, I could never go back to going through that pain. Yeah, to California, I did a rotation in South Africa in med school. I did a full semester in Australia in college, and then trips to Costa Rica, Puerto Rico, couple of other island destinations. Yeah, it's my love. But I think as you get older, unfortunately, there's been no Tom Brady effect here. The skills have really deteriorated, so it's mostly kind of lugging around a longboard and just kind of catching some small waves. But it's still fun.
The closest I've ever gotten to surfing is I watched Point Break. That was on TV yesterday, which is an awesome movie. But man,
It
you have
is
lived the
reboot or the original?
Oh, the original, yeah. The reboot, I don't even consider a movie. So you have lived the life. So you, when did you start Singular Sleep? And this is, so you basically, you practice telemedicine, you assess, you diagnose, and you treat patients. It's all HIPAA compliant. Can you tell us about Singular Sleep, when you started it, and what your method is?
Yeah, we launched on Veterans Day 2015. So we just celebrated our 5th birthday, which is a good sign. I think most small businesses, they say, don't make it that long. And the genesis was, I had been working in a traditional sleep lab, big sleep lab, where we did things the traditional way, which is pretty painful for the patient. The typical process is you go see your primary care doctor and you complain about symptoms like snoring or waking up despite getting 7-8 hours of sleep, not feeling refreshed or feeling tired during the day, or your partner says that you stop breathing in your sleep. And then the doctor would say, okay, well, you might have sleep apnea. Let's order a sleep study. Then you have to go spend a night in the sleep lab, and then you might have to go back and see your primary care, and they say, yep, you have sleep apnea. Let's go do a second sleep study where they start the CPAP and find the best pressure. And then you might get referred to a sleep doctor to take over management. And then after you get the pressure determined, you have to go to a durable medical equipment company. And so multiple trips, multiple providers can take a month or so. And I just thought that there's got to be a better way. And this also coincided with just complete, utter hatred of how insurance was getting more and more involved. And I didn't know whether I was the doctor or they were my boss telling me what to do, because everything sort of became their algorithm. So that was the biggest thing that was taking away from my enjoyment of clinical practice, was their paperwork and the documentation. I'm like having to do abdominal exams and stuff just to bill it a certain way. What does that have to do with sleep? Nothing. So it all kind of congeal to this idea of, what if we do everything remotely? Is that possible? And the answer I determined was yeah, and I think we can get just as good outcomes, if not better. So people had always been doing home sleep testing since it came out, and as the years have gone on, this has been validated and basically approved by the American Academy of Sleep Medicine, the governing board of the field, for patients at high risk for obstructive sleep apnea. They've come out with a position paper saying that this is an appropriate way to test. If you have more complicated cardiopulmonary issues, they recommend an in-lab sleep study. But for the vast majority of people, home sleep apnea testing is fine. And people were just starting to do telemedicine in certain fields back at that time. And I thought, well, this is just perfect for sleep medicine, because I don't need to examine anyone. It's not like if you're a dentist, you've got to get in there and see what's going on, or an orthopedic surgeon, you've got to, check that ACL. But we don't have to do that with sleep. It's all clinical with the sleep study. That's how we diagnose everything. And so what I did, and we were the first people to do this, was to combine home sleep apnea testing with online consultations, which now pretty much every state says that they are equivalent to in-person examinations for establishing the patient-doctor relationship. And I think everyone's now familiar with this since the COVID outbreak. People have been doing a lot more telemedicine. What about dentistry? Is there a role for teledentistry for certain things, or it just doesn't really work out?
Oh no, there is, especially because of COVID. There is. It's becoming a whole thing with teledentistry. Yeah.
Yeah.
And there's so many new softwares and systems coming out. So you were actually ahead of the curve. You were pre-COVID.
Yeah. So we were way pre-COVID. So the video consultation allows you to legally establish the patient-doctor relationship, and then I can treat them, basically. So, and then we were offering CPAP equipment too, where we have a DME license. So good system. Now, of course, not everyone, as you well know, wants to use a CPAP machine. And I've always been an advocate for whatever works for the patient. And in my interpretations, if they're appropriate, which is mild to moderate obstructive sleep apnea, I always include, besides CPAP, I always include oral appliances for sleep apnea and nasal EPAP as alternative treatment strategies. So, and that is where there could be a lot of synergy with dentists. I think dentists, a lot of dentists are doing this to a certain degree in their practice, some exclusively, and we would like to build relationships with dentists. I think dentists, most of them who are doing it, have some system figured out. They're using some provider, but I think what we do has an advantage. I think that it's important to use the right equipment. The least expensive way to get people tested right now is using this technology called PAT, which is peripheral arterial tonometry. It's basically an estimation of how many abnormal breathing events you have based on the change in the diameter of a finger artery. People like this because it's easy and it's cheap. But the problem is it's an estimation of your breathing events based on a change in the artery in your finger. It's not nearly as good, in my opinion, and many of my colleagues, as actually looking at the respiratory data. So the great thing is I can intuit dentists. I mean, we're clinicians. We're clinicians, doctors, dentists. We ultimately, the goal is to help the patient. I mean, yes, we want to be having business and making oral appliances, but we want to make it for the right patients that we know it's going to work for. I think dentists, like doctors, we know the downside of, okay, this is just, you know, if this doesn't work out, you've got an unhappy patient who spent a lot of money, and that's a problem. We want to set up people for success, right? So if you don't have a good handle on the severity and the phenotype of the sleep apnea, you're decreasing your chances for a successful outcome and a happy patient who's going to give you a great review and tell all their friends about you. You're going to have someone who's pissed off and trying to get a refund from you for $4,000 or whatever the fee is. And with the technology that we use, we actually can see more definitively what type of sleep apnea they have and how bad it is. That's really important, right? Because you're going to have better outcomes with people in the mild to moderate spectrum and who have purely obstructive sleep apnea, who don't have any complicated sleep breathing issues. All right. So the technology that uses the PAT really is not great at that. And I think the technology we use is superior. Also, you got to think about unfortunately, the alignment of incentives here. So most of the companies out there that dentists are using, I think every single one is not physician. It's not a physician-driven practice like we are. It's a business. And they outsource the reading of the sleep study to doctors, and they don't pay them very much money. And I hate to throw shade on my colleagues, but it does happen where, and you guys have probably seen this, and gals, wow, this looks like sort of a generic templated interpretation. Like they just copied and pasted, and they do, because some of these docs are only getting paid $40. I'm going to reveal the inside info. And so what's the motivation, unfortunately, for these doctors to give a really good interpretation and look hard at the raw data and help you to know what you're up against and help you be successful? Not much. Whereas this is what we do, and I'm paying myself to do the read, right? So it's all in alignment, and I want to make sure that this report is correct and that you have correct information so that you can be successful. So I think that you can rely on a physician-led practice that doesn't use PAT technology to get the most accurate results and set yourself up for success. And it's the other advantages are that if you're going to go through insurance, which some dentists are doing, I think from what I've heard, the meeting with me will enable the dentist to bill or the patient to get reimbursed for the device, if I've given them the diagnosis, and I think that helps their cause. Obviously, these devices can get pretty pricey, and to help more patients be able to manage that, they're going to want to try to take advantage of their healthcare benefits, of course. So, having that there, I think is helpful. But also, what happens when the device doesn't work and the patient is not doing well? Well, it's nice to have a lifeline, a board certified sleep doc who can jump in and help out with, maybe switching to PAP, or maybe a hybrid therapy with PAP and the device, or nasal EPAP and the device, or positional therapy or oxygen therapy or something like that. There's a lot of options on the table, even certain medications we can use. And I think that there's the potential for a really good working relationship there, rather than a sort of transactional one with one of these companies that's out there, um, which I think would benefit everyone, including and most importantly the patient, um, over the long term.
Yeah, I think that's one of the biggest barriers that that I can think of is the medical coding and insurance aspect of it, and also the what if I make a device and it doesn't work,
Right.
to what do I do then? So to have that team atmosphere with with a company like yours, I think is key. So you mentioned phenotype. So can you give a definition of what sleep apnea is and what the different
Yeah,
types
so
are?
that's the term I use, and I think it's a great term because there, to simplify things, there's obstructive sleep apnea, which is the airway is too narrow and repetitively obstructing or collapsing on itself. This one goes along with a lot of snoring. There's central sleep apnea. There's multiple different types of this, but basically the issue is that the brain and the lungs are not communicating well. In layman's terms, the brain is forgetting to breathe. We're not initiating enough of breaths to be sufficient. When you have a combination of obstructive and central sleep apnea, the most commonly used term for this is complex sleep apnea. That's not uncommon to have some component of central sleep apnea. And if you make an oral appliance for people, it's only going to treat the obstructive component. They may not have a good outcome. They may not end up sleeping and feeling much better. They may still be having a lot of events central. They may still be having a lot of DSATs, oxygen drops less than 90, which are a big problem physiologically over the long term. So how do you know if someone has what their phenotype is, obstructive, central, complex? You've got to do a sleep study. Some warning signs that they might be at risk for central. So there's a short list of 5 things that can cause central. There's always an underlying etiology, medical etiology to this. By far and away, the most common thing overall that I see in my practice is something to do with the heart, where it's not pumping out blood quite as effectively as it should. Most of the cases that I see where there's a significant component of central sleep apnea, it's a minor change. There's been a little bit of left ventricular hypertrophy or a little bit of diastolic dysfunction. Most of the cause for this is the patient has had high blood pressure, even borderline high blood pressure, or obstructive sleep apnea for years, or both, and they haven't done anything about it, and it's caused some remodeling of the myocardium, the heart muscle. When that gets very severe, it becomes congestive heart failure. That's pretty easy to pick up. These people are short of breath all the time, even at rest, minimal physical exertion. The other things that can cause central sleep apnea: kidney dysfunction. So if the BUN creatinine are not normal, they're elevated. Opiate pain medications. Living at high altitude. So that's very common. In fact, pretty much all of my patients in Colorado have some component of central sleep apnea. Also common in my patients in New Mexico, Utah, Montana. I've had a few people in the mountains of North Carolina above about 3,500, 4,000 feet. That's when I start to see that happen. And then the last issue is neurological problems that affect the brain or cervical spinal cord. Those are usually big honking things that you can tell someone has just by talking to them for a few minutes. But if I see this on a sleep study, then I do a rundown of all that stuff and I'll ask screening questions. The neurological screening questions I typically use if there's nothing documented in the history are, do you have chronic significant headaches or neck pain? If that's the case and I saw central sleep apnea, then I'm going to be getting an MRI of that area of the body.
Now, what is the percent difference of obstructive or central or complex? Is one more common than the other?
Obstructive is by far and away the most common form of sleep, but it's a spectrum. It's not, people think of it as a binary thing. It's very common to have a few central breathing events on a sleep study. We still say it's obstructive sleep apnea. It's sort of like a feel thing and a knowledge thing of when this is going to become significant for people. It's sort of, having done this for 12 years, okay, and there's some subtle findings. You can actually see, if you're looking very carefully on the equipment we use, what we call periodic breathing, which is this like undulation of the effort that people are giving out. And you'll see these like repetitive breathing events in a very stereotyped pattern. And even if there's a lot of snoring, that's a red flag for underlying central sleep apnea. You got it, I'll call that out on the report. And that's someone that, they may not have a great outcome with an oral appliance, or they may have a partial clinical improvement and may need something else to mitigate the central sleep apnea. That's what people should be thinking when we see that. Yeah.
Now, is snoring always associated with sleep apnea? Can you just be a snorer and you don't suffer from sleep apnea?
There's something called primary snoring, which is you have snoring on the sleep study, but you didn't meet the diagnostic criteria for sleep apnea, which is defined as having 5 or more abnormal breathing events per hour. And there's criteria that we use to define what an abnormal breathing event is. Not to go too far down that rabbit hole, but there are apneas and hypopneas. There can even be these subtle things called RERAs, respiratory effort related arousals. If you look in the breakdown of the sleep study report, it will give you metrics on all of this stuff. But in a nutshell, there are 3 types of apneas. There's obstructive apneas, which is where the airway completely collapses for at least 10 seconds. There are central apneas, which is the airways totally open, just the person forgot to breathe for at least 10 seconds. And then there are what are called mixed apneas, which start out as central, and then during the episode, the person tries to start breathing, but their airway has collapsed during that period of time. With hypopneas, there are central, obstructive, and mixed as well, but on the reports, we don't differentiate them. It's just going to say hypopneas. But in the narrative, if I'm seeing mostly central hypopneas, that's something we need to know. I'm going to call that out, as opposed to if I'm seeing mostly obstructive hypopneas. So that needs to be differentiated. That's important.
And who's at the most risk? Is it men? Is it women? Is it people over 50, obese? What are the risk factors?
We talked about the risk factors for central sleep apnea. I would just elaborate on the cardiac stuff. Other things that dramatically increase your risk for having a significant component of central sleep apnea are arrhythmias like atrial fibrillation and any sort of significant valvular disease. I'd say moderate valvular disease. So there's trouble getting through a valve, or there's backflow because the valve is incompetent. All those things should make you worry about central sleep apnea. With regard to obstructive sleep apnea, the more common type, there are a lot of risk factors. The classic case is a middle-aged man who's overweight or obese. And women are relatively protected from sleep apnea until they hit menopause. Then their rates equilibrate with men's. Importantly, women present differently with sleep apnea than men, premenopausal and postmenopausal. Classically, women present with more insomnia, what we call sleep maintenance insomnia, trouble staying asleep. They typically wake up at about the same times every night. The classic story is an awakening somewhere between 3 and 4:30, and then another one between 5 and 6:30. And as things really get bad, there may be a third between like 12 and 1:30. These are periods of time when we tend to have REM sleep. During REM sleep, muscle tone gets really, really low and the airway is very prone to collapse. And for some reason, women tend to be more prone to sleep apnea and REM sleep. So what happens is they go into REM, they have a cluster of breathing events or one really prolonged one, and they have such a strong stress response. The sympathetic nervous system gets activated. They wake up and they feel wide awake, at least temporarily. And the other difference is that women tend to complain more of fatigue than sleepiness. Men tend to complain more of sleepiness. A lot of people have confusion. What's the difference between sleepiness and fatigue? The way I think of it is that sleepiness is the tendency to doze off or fall asleep when you don't want to. Like when you're in a meeting, you're bored, your eyes are starting to droop down, you need the toothpicks to hold them open. That's sleepiness. Fatigue is a feeling of a lack of energy, overall global lack of energy. Women are much more likely to complain of that as a result of untreated sleep apnea. So besides weight, age, neck circumference is huge. So men with a neck circumference of 17 inches or more, women 16 inches or more, that's a risk factor. A lot of it is craniofacial stuff. So I like to tell patients about a third of their composite risk for sleep apnea is what they inherited from their parents. And that's the facial and jaw structure. So the retrognathia, micrognathia, shallow maxilla. So people with Down syndrome and people with from Asian backgrounds may have more at risk, even if they're thin. Asian people are frequently overlooked because as a whole, as a population, they tend to be more slender, but they can have really rip-roaring obstructive sleep apnea due to their craniofacial structure. But the bottom line is looking, the proof is in the pudding. So when you're in there looking in their mouth, you're going to see how narrow their airway is. We use this thing called a Mallampati score, which was determined, which was developed by anesthesiologists to determine who is going to be more difficult to intubate. And people can look it up online, or maybe we could put in the show notes, but that's a way of determining how wide or narrow the airway is. The standardized sort of exam. And, that's the bottom line, is how wide or narrow it is. People ask me all the time, well, what about my tonsils? My tonsils, should I get them out? And the answer is no. That's a factor for kids for sure. That's considered to be a first line treatment for kids who have obstructive sleep apnea. By the way, fairly prevalent, about 3% of kids have obstructive sleep apnea. So for that, it's either getting the tonsils, adenoids out, or CPAP. Most parents elect the tonsils and adenoids. But as we get older, as I'm sure dentists know, the adenoids tend to shrink up and go away, and the tonsils may still may know some significant tonsillary tissue back there, but it doesn't really help to take that out. That's what the research shows. And then behavioral factors are huge too. So smoking, alcohol use, particularly before bed, um, certain medications, anything that is going to decrease muscle tone. So muscle relaxants like Flexeril, Baclofen, um, benzos, Valium, Klonopin, stuff like that. Those can all exacerbate um, sleep apnea,
Can you go
obstructive
back
sleep
to
apnea.
children? Are children, are they typically more obstructive? And what about grinding their teeth? Is that typically a way where they're fighting for air, and that can be a symptom?
So for both kids and adults, bruxism is there's a strong association. The relationship hasn't been entirely worked out, but and I've done some presentations on this, and I've done some deep dives into the research. And the best theory I've come across is that in lighter stages of non-REM sleep, N1, N2, which usually happen in the beginning of the night, and then we have a little bit before we wake up, um, we're prone to what are called parasomnias, which are behaviors that occur during sleep or during partial sleep, partial wakefulness. Bruxism is considered a parasomnia. And the theory is if you have an obstructive breathing event, which terminates in your brain waking up, at least very briefly, that can set off an episode of clenching or grinding. So that's the theory. And if we treat the obstructive sleep apnea, it may help the bruxism. Of course, there are other etiologies. There's definitely, you know more than me, psychological factors, medications, other things that can, bad occlusion, malocclusion for sure, that can contribute. But there's definitely a strong relationship, and I think that holds true for both kids and adults. So it's a fellow traveler with obstructive sleep apnea.
Now, who typically calls you? Is it, are they referred by their PCP? Are they calling you directly because their spouse is hitting them because they're snoring? Have they suffered a scare while driving? What's your typical patient that is calling you for help?
All of the above. My first question is, tell me about, because usually there's a long period before people take action, and I want to understand uh, why are they here now? And my first question is, what made you decide to order the sleep study at this point in your life? And that helps me understand the motivation, which is important. This is a big change for people, whether they're going with CPAP or an oral appliance. It's a big deal to alter the way people sleep. And I think you've got to find the motivation, and you've got to harness that to try to ensure success. So a lot of folks, it's going to be my spouse or partner is sick of hearing my snoring. That's extraordinarily common. I keep getting elbowed. I have to go sleep in another room. A significant period of time, it's something scary. Like, I'd heard about the snoring for years, but then I woke up feeling like I couldn't breathe, and I want to get checked out. Or it's I had a scare, I had some chest pain, and getting a cardiac workup, and the doctor said sleep apnea can cause heart attacks. And I'm trying to get really healthy now, because that was a real wake up call. And other times it's daytime symptoms. I am so tired, I'm falling asleep at work. My manager is watching me. I think I might get fired, or I just don't feel like I'm functioning on all cylinders. I can't watch a movie. I fall asleep immediately. It's affecting the quality of my life. So it's a variety of things that tip people over.
Now, is the medical community totally on board with sleep medicine, or are you finding that a lot of patients are getting to you and it's a little too late, or it could have been caught a lot earlier?
Complex question. So the statistic is the average physician gets 1 hour of sleep medicine training in their 4 years, which was probably better than it was 10 years ago when it was probably zero.
Right.
So I think the awareness is fairly good in the medical community, but also I think we've done a really good job of raising awareness in the patients themselves. So patients sort of know what to look for. I think there's been a transition away from chronic habitual snoring and making strange or concerning noises in your sleep as like something that was kind of a funny uh thing, like, I don't know, body odor sort of thing, to like, oh, this could be a medical problem. And I think largely the public is aware of that. And I think entities like the American Academy of Sleep Medicine, National Sleep Foundation have done a really good job of educating the public. Where we have a problem a lot is with physicians, it's usually primary cares, who the person walks in and has all the symptoms of obstructive sleep apnea, but in the primary care's mind, they don't fit the bill. They're thin, healthy, and what happens is this may delay the diagnosis by years. Usually, they'll say, "Oh, I don't think you have sleep apnea. I'm going to put you on Ambien." And the person's like, "I keep waking up and I feel like crap when I wake up in the morning." You put them on Ambien, it prevents them from waking up, but it doesn't really solve the problem. It actually exacerbates the underlying problem. And then, time goes on, they develop high blood pressure, and then, oh, maybe we should think about obstructive sleep apnea. And then they start the process. So that, in older folks who have sleep problems, it's just sort of felt in the medical community like, oh yeah, well, your sleep quality goes down as you get older. That's just the way it is. But a lot of time it could be correctable. It could be a diagnosable sleep disorder. So I think we've come a long way, but there are certain sort of stereotypes that we need to overcome. A very significant portion of my patients are thin. They just have really bad retrognathia or other anatomical issues that are causing this at baseline. Their airway is just narrow.
Okay, so the patient has either been referred or they decided to finally take some action and get the study. Typically or traditionally, it was through a lab, a brick and mortar office, a lab, whereas yours is a home sleep test. Are a lot of these traditional clinics or labs, are they closing up because of COVID now? And it's, yours is so much more convenient where, a lot of people don't want to go anywhere. They don't want to leave their house. And they're a lot more comfortable in their house, and you may even get better, more accurate results. Are you finding that these traditional clinics are closing down?
Yeah, so there was a couple of good things that you brought up in that I want to address. So it was getting harder and harder to run a sleep lab even before COVID, because the home sleep testing is cheaper, it's more convenient, it's more comfortable, and maybe more accurate. I personally think it's more accurate. The downside is we don't have electrodes in most testing equipment that's used to determine if you're awake or asleep. So it's an estimate of the whole recording is considered to be sleep. That said, I've read so many thousands of in-lab and home sleep tests that I can kind of determine with a fair degree of accuracy if someone's awake, and I throw that data out to make it as accurate as possible. So if I see when we're asleep, we breathe very regularly. It's completely different than when we're awake. If I see someone breathing very regularly, I know they're awake, and I throw that data out to try to make it as accurate as possible. The accuracy issues are whenever we sleep somewhere new, there's something called the first night effect. We think it's because it's like an adaptive mechanism to be a little bit more alert in a novel environment. This might not be safe. I've never slept here before. So we typically skip our first period of REM during the night, and we have lower sleep efficiency, meaning our brain's waking up more during the night. So it's not a very good approximation of what's happening at your home every day. With a home sleep test, we avoid that issue. We also, with a home sleep test, see what I think it's another ecological validity factor. So a lot of people are having a drink or two or three, or smoking a cigarette or cigar or something like that. And when you send people to the sleep lab, they're not doing that. You're taking away their normal routines. They also may be avoiding taking their sleeping medication. We tell people take all the medications exactly as you would. We want to see what's going on as close to a night to night valid situation as possible. And I think the ecological validity is higher for the in-home sleep studies than in lab sleep studies. The other problem is that the sleep lab, it's set up to do things their way. For staffing purposes, it's more convenient for them to have you go to bed at 9:30 or 10 at night and be woken up at 5 or 5:30. How many of us sleep like that? So it's often very hard for people to fall asleep. It's just too early. We're not sleepy yet. And then you wake up at 5:30. You may have missed your last REM period because that's not when you normally wake up, and you're going to feel like crap the next day. People are not going to be happy. So, we want to let people sleep their normal routine. That's another important factor too. So, sleep labs are struggling because of the cost, the convenience, all the benefits of home sleep testing. And then COVID hit. And then you're looking at, okay, what's the risk of infection? How do we sterilize? We reuse this equipment over and over, all these electrodes and stuff. How are we going to sterilize this? And then it basically came to most sleep labs just closed down. And then they reopened, then they had to screen everyone coming in for COVID with nasal swabs and then temperature checking. Then they could only limit capacity. Then they reopened, but capacity was so low, there's huge backlogs now. I have people telling me they're waiting months to get in for an in-lab sleep study. So that's not good either. So we're telling them, okay, this is really important. You got to get this checked out. If you don't, it can cause bad stuff, high blood pressure, heart disease, stroke, dementia, and then hurry up and wait. This is so important that you're going to have to wait 3 months to get in for a sleep study. No, that's not going to work. I mean, that's cognitive dissonance. We have to be consistent with our message. So if it's really important, then you should get it done in a timely fashion. And that's, something we can really do with our system. We've got a lot of these units and they're just constantly cycling in and out, and we can get the testing done very quickly. And when you've got that motivation, you don't want to lose it, because people they'll forget about it. They'll just keep putting it off. But if you can get them to commit, okay, yeah, I see that's important, I want to get tested, you got to push that through right then. That's my experience.
It seems like a no-brainer. I mean, the comforts of your own home. I mean, I don't think I could sleep in a sleep clinic. I have to get up and pee, and there's wires on you and people watching you, and there's cameras on you. I mean, that's that's not comfortable. Okay, so, and then there's less of them, so it's even harder to get an appointment. So like you're saying, it could be pushed off, and that patient is motivated. So it just seems like a no-brainer to do this from home. So can you tell us about your specific test? How does it work? Do you ship it to me in the mail? Does it have good instructions? I'm a disaster with instructions. It takes me 2 hours to something that says 10 minutes to build for my kids takes me 2 hours. So I need good instructions. How does all that work?
Yeah, so we've learned a lot in 5 years about how to maximize the chances of a successful study. So the apparatus is pretty darn easy. That said, never underestimate what people can do to screw up technological tests, right? So the device that we use is the Philips Respironics Alice Night one. It's a great one. There's a couple that I would say are great. The ResMed um, uh, one is equally as good. So it involves a RIP belt, which is a quantitative measure of respirations. And on that belt is the brains of the unit, which also measures body position, very important. Then there's a nasal cannula that measures air flow. So how much air is actually moving in and out of your airway. And then there's a pulse oximeter, and that's it. So the test arrives with, we've created these bespoke directions on a piece of paper to make sure that we have a high chance of success. One of the things we really love about this unit is that in the morning, I call it Simon Says. You push a button, and if you did good, for all the 4 pieces of the pie light up. If you didn't do a good study, you won't get all 4 pieces. Do it again. And we also, there's a video that we have that kind of walks people through exactly what to do. Now, does everyone look at the instructions and watch the video? No. And then what we do is we tell them, don't return the equipment until you've spoken to someone. So we tell, they'll call in the next business day, speak to one of our representatives who will troubleshoot with them, then we'll have them do it again. If they still manage to send the study back and there's not sufficient data, which is, I'd say we've got that down to maybe 2-3% of the time. What we do, the technologist will upload it. I'll look at it and say, you know what, this is just not good enough quality. I can't read it, or there's just not enough data. Then we will offer to redo it for just the shipping and handling. The goal is we're going to get a good study by hook or by crook. We're going to do it or die trying. So it just goes on and on until we get the result that we're looking for, an accurate reading. But we've been doing it for so long that I think we have a pretty good system that ensures a high degree of success.
So you're looking for one night's data where you're
just
getting
need one night. Yep. There's minimum night-to-night variability with sleep apnea testing. We just need one night. So we tell people to get 6 hours of sleep at least, and that we're needing at least 4 hours of good data. But really, we only need 2. We don't tell them that, but we do want as much sleep as possible. But in a pinch, we can get away with at least a few good hours of quality data. It's accurate enough to make a determination.
Is the study typically covered by medical insurance?
Yes. So we don't deal with insurance directly, but we will give them all the codes and documentation that they would need to submit to insurance. If they wish to do that.
So let's say I made the decision, I called you, you sent me the sleep study, you got the data that you needed, you've diagnosed me. Is CPAP still the gold standard for treatment?
CPAP is considered the gold standard for treatment. Now, that said, for mild to moderate cases of obstructive sleep apnea, oral appliances and nasal EPAP are this thing called Bongo RX, which is an interesting device that it fits in your nose. Basically what it is it's a membrane, and air goes right through on inhalation, but on exhalation, some of the air is blocked and basically ricochets back down your airway and helps to pop it open. Those are considered to be first line alternatives. So interchangeable treatment options, totally fine if people want to go with that. And then for severe obstructive sleep apnea, oral appliances are considered to be a second line treatment. So if you failed CPAP, or I think myself, and I think most of us, if the person was just stomping their feet, I'm not going to use CPAP. Well, let's do something to help you. Let's go with an oral appliance. We're going to counsel you that it's probably not going to be 100% effective. But if we can get your AHI down from 50 to 15, that's a whole lot better than nothing. So, I mean, I think it's all about looking at the big picture here.
Now, what does EPAP stand for?
Expiratory positive airway pressure.
Okay. So now you also you actually sell some of the oral appliances on your site as well?
There's an oral appliance called Apnea RX that we have up on the website. And there's another one in this category of temporary oral appliances that we don't carry. I forget the name of it, but it has a huge prong that comes off the front. And the Apnea RX is kind of I don't really recommend it to people that much. It's sort of like a flimsy device that's made to see if you can tolerate and benefit from this. And then you want to be moving to a custom one made by an appropriately trained and experienced dentist. It's a boil and bite system that it's relatively bulky for one of these devices, and it doesn't have lateral movement. It's not very comfortable. But for people who are not ready they're sort of on the fence about, oh, my dentist quoted me $3,000 or whatever. I don't know if I want to do that. This is a reasonable thing to try, I think, to see, are you going to benefit from it without breaking the bank? And they usually last for a few months, and then, then it's time to get the custom one.
And so that's the apnea. So I have something like this. This is an EMA that I use for snoring.
You wear that yourself?
I do, yeah. I was getting constantly elbowed in the ribs by my wife, so it's I call it the the divorce saver. So you also have something similar that's a mandibular advancement appliance. That's
we don't.
custom?
That one uses these like bands almost. What would you call them? They give you like 3 or 4 of those, right? And you can
Correct.
adjust.
Yeah.
We don't have any. So that one has to be made custom for you, right? You had to take impressions and maybe bite registration or something like that. So no, we don't get into that sort of thing. Just one footnote, you asked me, so how would a person go about this? They would order it and just, so with the dentist, what we would do is, what I think would make sense is the dentist could certainly refer people directly to us, and some do. But I think what may make a lot of sense is the dentist orders and pays for it and then passes it on to the patient. That's part of the whole cost of the program. So, like you led off with the beginning, we put a couple different packages together for people, from 1 sleep study up to 2 sleep studies and the consultation, really. So a lot of dentists are going to want a follow-up sleep study to assess for efficacy. Not everyone does that. That's kind of a judgment call. So, I think that if I was a dentist, I'd probably think about that, kind of like including it in what I'm billing the patient as a part of the whole program.
Now, what you mentioned earlier on in the conversation about body position, I have a whole system, actually. I sleep on my side. I have a Tempur-Pedic pillow. I have a leggy pillow that I put between my legs, and I have a huggy pillow that I hold. I've got a whole thing going on.
You really don't want to use the CPAP. That's a lot of effort.
I know there's a lot going on there. So what's the difference in body position if I'm a back sleeper, a side sleeper, or a stomach sleeper?
So most folks with obstructive sleep apnea will have a positional component to their sleep apnea, meaning that it's worse when they're on their backs. We don't see that as commonly or as dramatically with central sleep apnea. So basically, it makes total sense. When you're on your back, you've got gravity working maximally against you, right? Pushing the soft palate, uvula, tongue base straight down, maximal obstruction. So getting off your back will help the cause. You're going to take away gravity's impact on your airways patency. The other thing people start to do, and I see this with extreme cases, severe cases, they'll start popping up the head of their bed with pillows. Then eventually, in like end stage sleep apnea, they can only sleep in a recliner, sitting up straight. Occasionally, I'll see that. And then you're trying to stay on your back by using the huggy pillow and the foot pillow. Those, unfortunately, the research we have doesn't work that great. The oldest, you got to use something physical. The oldest and least effective physical barrier is sewing a ball, usually a tennis ball, into the back of your nightshirt. What happens is you go to your back, you wake up, feels terrible, you roll over. Unfortunately, we know you can't train your brain to stay off of your back. You just can't do it. Some people will have such terrible sleep apnea that right when they go to their back, they basically start essentially dying and they go right off their back. And so they won't sleep on their back because their sleep apnea is so bad. But you can't really train your brain to avoid your back. The better version of that is a barrier device that prevents you from going to your back in the first place. Something either, there's a lot of these that have a foam cushion or inflatable cushions on your back. It prevents you from going to your back. The problem is it tends to keep you on one side all night long. It's really weird to roll over your face, over your stomach to get to your other side. So most people don't do it. So it typically keeps you on one side all night, which tends to get uncomfortable. It builds up the pressure points, and some people, I'll also include positional therapy as a first line treatment. If they don't have sleep apnea on their sides, they only meet the criteria when they're on their back, then positional therapy is considered to be a first line treatment too. I'll include that in their options. The people that try that usually can't tolerate it for the long term. Every once in a while, there's a rare bird that's the solution for them.
Yeah. So, to wrap things up here, I think that, as dentists, we see patients, at least twice a year. So we're seeing them more often than their PCP. So we have the ability to, in our questionnaire, we have, certain questions we ask patients that may help us assess some signs or symptoms of sleep apnea.
Yeah.
And the key is, like you were saying, to get the patient tested early. I see some patients, 5 to 10 times a year. So if we're constantly asking them and
just to glom onto what you were saying. So, with the screening, the questions that you may ask, I might suggest, the ones that we use in the medical field are typically the stop bang questionnaire, which has a very high sensitivity and specificity, as well as the Epworth, which is an assessment of sleepiness. I also use the fatigue scale, which is more sensitive for women. We've put these online in a digital way where you can just go through it, rip through it, and get the score. It will calculate for you immediately. So we could put the links to those on your website too. They're totally free and might be a good tool for dentists out there who want to use one of these validated tools to kind of look at risk.
Oh, that's great. Yeah, I think anything that we can add to help with our questionnaires is to assess these patients is great. So, all right. So again, thank you so much,
Yeah,
Dr.
my
Joseph
pleasure.
Krainin.
It's been a great conversation. I enjoyed getting more into the weeds than I typically do on these podcasts. It's great.
Yeah, and I like the doctor is online. That's Dr. Joseph Krainin. I smell a T-shirt with that slogan. I think you're onto something with that.
Yeah, I don't think I'll be able to sell enough to retire from my day job, but maybe, people, you never know what's going to take
Yeah,
off, right?
little side hustle.
Yeah.
So Dr. Joseph Krainin, president and founder of Singular Sleep, and you can go to Deals for Dentists and find their offers. And thank you so much for joining
My
us.
pleasure.
I learned a lot today. Any last nuggets or words of wisdom you want to tell the young dentists out there?
No, I think feel free to email me and we'll get, I think my personal email address probably up for the dentist. I don't want, the patients getting that, and we could, have a discussion and figure out, something that's going to work. We're just really looking to build relationships and help you be successful. And, we're happy playing our role and just doing the testing. And we understand that people are there in your office because they want the oral appliances. And, I think some sleep doctors, physicians are just so one track mind about CPAP, but I'm not one of those folks. And we definitely want to work with you to, make sure everyone's happy, because ultimately, it's all about the patient. And if they want the oral appliance, then, let's facilitate that as long as they're the appropriate candidate and they know what the likely outcomes will be.
All right. Thanks so much.
My
Let's
pleasure.
be in touch. Yeah.
Okay.
I
Sounds
enjoyed
good.
it.
Okay. Have a happy Thanksgiving.
You too. Take care.